Dr. Lidia Schapira is a professor of medicine at Stanford and the director of the Cancer Survivorship Program at Stanford Cancer Institute and Comprehensive Cancer Center. Dr. Schapira is a board-certified medical oncologist with 30 years of clinical experience. She was on the faculty at Harvard Medical School and a member of the breast oncology program at the Massachusetts General Hospital from 2002 to 2016, and then joined the faculty at Stanford in 2016. She is a co-investigator in a longitudinal study of young women with breast cancer. She is the editor of Essential of Cancer Survivorship, a guide for medical professionals, serves as associate editor for the Journal of Clinical Oncology, and has published over 100 original peer-reviewed articles in medical journals. Ladies and gentlemen, please welcome Dr. Lidia Schapira.
Good afternoon. It's a pleasure to be with all of you today to talk about updates in the treatment of metastatic breast cancer. The topics I'd like to cover with you today are first, living with metastatic breast cancer. I'd like to talk a little bit about thinking about our cancer mindsets, managing symptoms, choosing treatment, treatment updates for triple-negative breast cancer, HER2-positive breast cancer, hormonally sensitive breast cancer, a little thought about clinical trials and the potential benefits of participating in clinical trials, and end with a reflection, leaving plenty of time for questions. So first, let's think a little bit about what it is to live with metastatic breast cancer. We know that it's unlikely to be cured, although we're always hopeful that newer treatments will even change that paradigm. There are so many meaningful discoveries and newer systemic therapies that have improved the prognosis that there is a really very legitimate reason to be very hopeful that we will continue to improve upon survival and also improve treatments that will allow so many more women to live with metastatic breast cancer as a chronic illness. I want to introduce to you the idea of survivorship for people, mostly women, but certainly people living with metastatic breast cancer. So the idea of survivorship is to think about everything that happens after a diagnosis and for the rest of one's life. And there's a growing literature and interest in this idea of meta-survivorship, and that is to include people living with metastatic breast cancer in all of our efforts to do more research and think about living with and surviving with metastatic cancer. So related to this is the way that we think about living with cancer, whether it's at the time of initial diagnosis or later on in the cancer trajectory. And we bring to the illness into the treatment our assumptions and our ideas about what this means. So people living with cancer may have formed certain ideas about what that means in terms of their identity, in terms of their health. So let's start by thinking about what mindsets are. They're assumptions that we make that help us to understand our experiences. Mindsets about the meaning of cancer and the role of the body may be impactful on how a person lives with the illness and even on their health outcomes. So what I'd like to share with you is the idea that adopting a mindset that cancer is manageable or even an opportunity to grow may bring with it a sense of hope and meaning, and may allow a person to become more engaged with treatment and to be more confident in their ability to handle all of the challenges that living with this illness inevitably brings. So adopting the mindset, for instance, that cancer is a catastrophe may actually lead to despair and disengagement, making an already difficult time even more challenging. So one of the questions I have is, how can we possibly change our mindset to adopt a more beneficial one when we encounter a very important life challenge, such as living with a chronic illness, such as living with metastatic breast cancer. It's very important, thinking about managing a chronic illness like cancer, to also think about monitoring symptoms and using the ability to monitor symptoms to get expert advice and to better manage the symptom. There are now many apps that are available free of charge, some by professional societies, some by local and national or international companies, that allow a person to really track their symptoms over the course of a day, a week, and even share that information with the clinicians so that they can get access to advice that allows them to manage that symptom better and control it. And that could be something like nausea or something that perhaps is more difficult to control, such as fatigue. This brings us to the idea of self-management, and that is one of the key areas, I think, these days when we're thinking about living with an illness like cancer. And that is, how does a person learn to gather sufficient information and then allow her to use that in order to manage symptoms and live as well as possible? So, how do you find sites, for instance, that provide that information that you can trust? It's a very important topic to discuss, and I'll be very interested to hear some of your thoughts in the Q&A. I think this is key, to have access to sites that you can trust, that has expert vetted information, that perhaps provides practical tips for managing symptoms. I certainly have many patients who found that in support groups, and some of them that have connected to people that they perhaps may have never met in person, but who share an illness and share the ability to communicate practical solutions for dealing with festering symptoms. Social support is also very important. It's essential. There are many studies that have shown that feeling supported or being in a relationship or having a supportive community actually can help a person manage many of the different aspects of living with cancer as a chronic illness. Choosing treatment is something that's really important for people living with metastatic breast cancer, and something that perhaps has brought you to this program today, wanting to learn more about specific treatments for this disease. Very important for people facing this situation of being diagnosed with metastatic disease is to confirm the diagnosis and to confirm the receptors. This is usually done by obtaining, if possible, a tissue biopsy of the cancer for assessing receptors, including some of the newer ones. So not only do we look for the hormonal receptors, but increasingly we're looking for PD-L1, which may help us identify people who might benefit from immunotherapies. We also look for what we call genetic alterations. This is different than testing to see if you have inherited a susceptibility to cancer. This is testing the tumor to see if there are some mutations in the genetic material in the tumor. One of them is this PIK3CA mutation, because again, we now have drugs that target those specific mutations. So the thought increasingly is that if we can identify some of the mutated genes that are driving the growth of the cancer and then develop a treatment that specifically targets that, we have a good chance of stopping the growth of the tumor. Increasingly, we are using what we call liquid biopsies, which are samples of blood, for instance, to look for some of these mutations if we don't have access to the tissues. There are new emerging targetable mutations in breast cancer, and that includes what we call TRK, also the microsatellite high tumor mismatch repair deficiency enzymes, and the tumor mutational burden. These are terms that until recently we weren't using for breast cancer, but increasingly are being identified as perhaps being important in driving the growth of that metastatic breast cancer, and may lead us to think of novel treatments that may be beneficial. We also want to do germline testing for the genes that we now know are associated with breast cancer, such as the BRCA1 and 2. And again, because we now have a group of drugs that specifically targets those tumors and may be beneficial. It's important to stage the cancer to see and determine the extent of disease, to think about the need for treatment on two different levels. One is continuous treatment, and the other is intermittent treatment. There are situations where we just want to maintain treatment, and there's some when we really need to include treatment breaks, both to improve quality of life and also because it may be possible to maintain a remission without having continuous treatment. So thinking always about quality of life and how treatment will affect quality of life is really key in finding the right treatment for an individual. And again, I want to stress here that the mind-body connection is very important because it's important to feel confident about one's ability to handle a treatment. It's important to feel engaged in the treatment, and that will make the situation far more bearable and will make sure that the person who is getting the treatment also is properly engaged in the treatment. Supportive therapies play a huge role for people living with metastatic breast cancer and receiving treatment. So making sure that if necessary, there are therapists involved that deal with mental health or rehabilitation or lymphedema, nutrition, all of these to support the individual while she's undergoing treatment. So think about choosing treatment as choosing wisely. It's important to select a therapeutic strategy that depends both on the tumor and the biology of the tumor, as well as the individual person. So these are the clinical factors, with the goal being of customizing and tailoring the approach to best treat and deal with the situation at hand. There's a specific sort of subtype, I would think, is a way to think about it, of metastatic breast cancer. That is when there is a single site called an oligometastatic site of disease. So somebody may have disease only in a spot in their spine or only in a spot in their liver. And sometimes we even think about giving local treatment. In general, when we think about metastatic breast cancer, we think about treating the entire body. But there are situations where even delivering a local treatment may be hugely beneficial. Every conversation about treatment is really a test of the patient-clinician relationship and communication. So it's important to be very clear about what it is that we're trying to control with treatment, what the goals are, in order to think about what options there are at that particular point, and then engaging in a good discussion about potential trade-offs in terms of potential side effects, potential risks of treatments, and also, most importantly, what can be gained by receiving that treatment. So when we think about how we make these decisions and how clinicians think, we also have to think that many of our recommendations, hopefully the majority, will be based on evidence, on what has been shown to work in similar populations. So let me just take a second here, a minute, to tell you how we define success and failure in research studies. There are very specific criteria that are used when we are doing research. So if you participate, say, in a clinical trial, you may know this, for instance, from your own experience. There are criteria that have been developed to evaluate whether or not a treatment is helping that individual with a disease. And that is important to standardize reporting of results in clinical trials. So if we are treating in that setting, according to these RECIST criteria, disease progression, or that means that the disease is continuing to grow in spite of treatment, on, say, a CAT scan or PET scan, is defined as any of the following: a greater than 20% increase in the sum of the measurable lesions that are being compared, compared with as small as some previously reported. So if it's 20% larger, then we think that the treatment is not being effective, or we define it as treatment failure. The appearance of new lesions, a worsening, for example, of some lesions in bones. Measuring bone responsiveness is a little bit more complicated because sometimes it takes a very long time for us to see responses on imaging studies. So with that in mind, let's think about now in the clinic, what are the reasons to change treatment? So for those of you who are living with metastatic breast cancer or know somebody being treated for metastatic breast cancer, you know that we often define, the duration or the length of treatment based on the response and the tolerance. So if somebody is tolerating treatment well, and we think that it's working, we continue. But if there's intolerance to treatment because of side effects, that would be a reason to stop, or because there's a decline in physical function, or somebody just is not doing well, or if there is an appearance of new metastases or an increase in the size of previously documented metastases. So that's how we think both in the clinic and in research about the need to change treatment, and or we define treatment failure. So now let's get to what probably has brought you here in the first place, which is to really think about how we've made advances and what's new. Let's start with triple negative breast cancer. So for those living with metastatic or living with triple negative breast cancer, there is a lot of hope in immune therapy. Immune checkpoint inhibitors and chemotherapy is now offered in first-line treatment for patients who have PD-L1 positive disease, meaning those that we find from their tissues analysis that are likely to benefit. And this is now using a particular drug called pembrolizumab, also known as Keytruda. Also, for those with triple negative breast cancer, some who have germline mutations in BRCA1 and 2 are being treated with a class of drugs that we call PARP inhibitors. And this really is getting us more in the area of targeted therapies. For those living with triple negative breast cancer, one of the great improvements, I think, in the last couple of years has been the emergence of this drug, sacituzumab govitecan, also known as Trodelvy. It's an antibody drug conjugate that targets a cell surface antigen that we call TROP2. So it targets TROP2. TROP2 is upregulated in breast cancer, and this drug is very specific. So it delivers the chemotherapy payload, as we call it, into those cells that have TROP2. The FDA has approved this drug for people who have unresectable, locally advanced, or metastatic triple negative breast cancer who have received 2 or more systemic therapies, at least one of them for metastatic disease. PARP inhibitors are drugs that can be taken by mouth. 2 examples are the drugs olaparib, known as Lynparza, and talazoparib, known as Talzena, both FDA approved for germline BRCA1 and 2 mutation carriers with metastatic HER2 negative breast cancer who have been previously treated with chemotherapy. And they can be used, talazoparib has been approved also for locally advanced or metastatic breast cancer. And I give you here the trials that led to these approvals. Sorry, I'm just trying to activate my queue here. So I think we're good now. So these drugs, and I've given you the names of the trials that led to their approval, can be used sequentially after or before chemotherapy rather than at the same time. We don't know, for instance, if we can combine these with some of the other new agents that are used in the treatment of breast cancer, such as the class of drugs known as CDK4/6 inhibitors. So let me move over now to the treatment of HER2 positive breast cancer, there's been a lot of advance and a lot of excitement about new treatments for HER2 expressing tumors. And as you very well know, HER2 directed therapy relies on having monoclonal antibodies that target HER2 in combination with either hormonal therapy for triple positive cancers or chemotherapy. These monoclonal antibodies include the drugs we know as Herceptin, trastuzumab, Perjeta, pertuzumab, and HER2, famtrastuzumab, and adotrastuzumab emtansine, a mouthful, TDM1. Other options for treatment of HER2 positive cancer are the tyrosine kinase inhibitors, drugs like tucatinib, and lapatinib, and then the drug margetuximab. And chemotherapy drugs that are combined with these drugs are drugs you'll recognize, such as capecitabine, Xeloda, or most usually drugs like Taxol, Taxotere, that come from the family of drugs we know as taxanes. For those who have triple positive breast cancer, meaning hormonally sensitive and HER2 expressing breast cancer, we can often treat with hormonal agents and these monoclonal antibodies. This drug, Enhertu, famtrastuzumab, has really received an enormous amount of attention in the last year. Famtrastuzumab deruxtecan has been approved by FDA for people with unresectable or metastatic HER2 low breast cancer who have received prior chemotherapy for metastatic disease or developed a disease recurrence within 6 months of completing their adjuvant treatment. And the reason that there's been so much excitement is that in the past, those who benefited from some of these HER2 therapies were thought to be, and the application restricted to, those whose tumors expressed a lot of HER2. But it appears from very good and rigorous trials that even a modest or low level of HER2 expression is important, is a target clinically, and studies have shown that this drug can really benefit a much broader segment of the people living with metastatic breast cancer. I've put here that it can cause pneumonitis because, as with many cancer treatments, we have great discoveries, but we also have to be very careful about the potential risks associated with taking these drugs. For those with hormonally sensitive breast cancer that's HER2 negative, we have lots of options. And this is a particular kind of metastatic breast cancer that's associated often with longevity, meaning that people can live for many, many years with very good quality of life. And although they do need treatment almost, I would say, on a continuous basis. So we can treat with endocrine therapy alone to either block the utilization of estrogen or deplete the estrogen levels. For women who are premenopausal with metastatic breast cancer, we recommend ovarian suppression, meaning using a drug to block the production of estrogen by the ovaries, so to make them menopausal. And for those who are postmenopausal, for whom the ovaries have stopped producing large amounts of estrogen, we use drugs that further reduce production. So when a woman goes through menopause and the ovaries shut down, there are other glands in the body and other organs that produce estrogen, and that is in the adrenal glands, two little glands that sit on top of the kidney, in breast tissue itself, in muscle and skin and fat. So there's still ongoing production, and these drugs that target the enzyme aromatase basically temporarily block the ability to produce estrogen. So the whole amount of estrogen that's available to the person and the tumor is lowered. We have drugs that degrade estrogen, and the drug that you'll recognize probably is fulvestrant or Faslodex. That's available only as an injection, whereas the other drugs I've mentioned are available as pills. Fulvestrant Faslodex is a very important drug used in the treatment of metastatic breast cancers. There are also estrogen receptor modulators, drugs like tamoxifen, that's used in treatment of metastatic breast cancer, although much less frequently now than it was 20 or 30 years ago. And the drug raloxifene, which is not really used for metastatic breast cancer, but is used increasingly in prevention. We can combine estrogen therapy with targeted agents. So, for those, for instance, whose tumors have mutated PIK3CA, there's a new drug called alpelisib that has been combined with a hormonal backbone and has been very effective. There are drugs that target the mTOR, and that's a drug called everolimus, and that's been around for quite a while, maybe about 15 years. And the newer class of drugs that target the CDK4/6, and those are the drugs that you are probably more familiar with, drugs like ribociclib, palbociclib, abemaciclib. And these are the abemaciclib is Verzenio, and I have to think about the pharmaceutical names for the other two. Among new drugs, and there's a lot of excitement, I think, among my colleagues, are to increase the number of drugs that can be taken, especially by mouth, that serve as estrogen degraders. One drug that is under review, for instance, is this drug elacestrant that has been tried as an oral target of the mutated estrogen receptor. So I think we will hear more about that in months and years to come. And then drugs that target the androgen receptors. So we think of androgen as male, but there are many cancers that show that there is an androgen receptor in many breast cancers that could also be targeted. So this has been an area of study now for many years, I would say decades. And I'm hopeful that eventually we will find also a subset of tumors that may respond to these kinds of interventions. Not to forget the importance, again, of supportive therapies. One of the areas where breast cancer metastasizes frequently, especially hormonally sensitive breast cancer, is bone. So it's important to use bone therapies to reduce the risk of having a fracture and having complications that we used to see decades ago and now are very rare. So the rise of calcium leading to a very uncomfortable condition called hypercalcemia, or many of the bone-related problems such as fractures and so on, can be decreased by using drugs that are effective at sort of cleaning out the bones and fortifying the bones. And many of the drugs, or some of the drugs that are used in this space, are the drugs that you will recognize as Zometa, zoledronic acid, or Xgeva, denosumab. One of these is given intravenously, another subcutaneously. Clinical trials really provide more options for treatment, and it's really important to think about it. I think from the moment of diagnosis of metastatic breast cancer, there always will be some trade-offs that need to be considered, especially if we think that there may be less information about side effects of novel drugs. There may be more testing that's required, which means perhaps more visits, more blood draws, even more biopsies. But it is a way of not only becoming sort of a citizen involved in research and partnering to advance the field, but also may provide a personal benefit if you have access to novel treatments, especially those that show that they probably could benefit you if the tumor that you harbor has certain characteristics. It's very important, again, as I said before, to partner to advance science as well. So my reflection is that the best advice I have for a friend or a patient with metastatic breast cancer is to be well informed. So to be armed with reliable information about treatment, to look for and fortify your own inner circle of supporters, your network of supporters, to take the time to adopt a mindset that assists you in managing the illness and to make what may be tough decisions, to develop and cultivate a good, open, honest channel of communication with a cancer team, to be so that you feel that you're known, that you're understood, that you can ask questions and have good answers, in addition to having prompt attention to your symptoms. And all of this will prepare you and make you feel that you're more ready to face a challenging situation and to make tough decisions as they need to be made. So with that, I'd like to thank you and open up for Q&A.
Great. Thank you, Dr. Schapira. This is Carly from BACC. I'll help moderate the chat for questions. I'll start with, we're wondering, what are you most excited about in the metastatic breast cancer space? I know you talked about some new research and various targeted therapies. Is there a specific area you feel like is particularly exciting or ripe for development?
I'm very excited about a combination of things. One is to really think about this idea of meta survivorship. So living well, living long, and taking advantage of both the science and the extension of life in many ways, and relief of symptoms. We have made, and it's hard for me to be more excited about one area over another, because I think all of these, if you can use them sort of wisely, can deliver what you want, which is not only more time and eventually someday perhaps a cure, but also better quality of life. So I'm very excited about finding targets for be based on genomic profiling of tumors. I'm very excited about finding targets for those living with triple negative breast cancer that have for so long not had this hope. I think that the HER2 space has been absolutely amazing in sort of expanding the amount of treatments. And for all of the patients, who are living with hormonally sensitive disease, I feel we've been stuck for a long time with using the same drugs over and over. And I'm very hopeful that we'll make more progress, combining selective estrogen degraders with estrogen blockers, and that particular group of patients will be able to live longer and longer without having to resort to more toxic treatments like chemotherapy. So all of that excites me.
Great. Thank you for that. Another question we have is, what is the best strategy for someone with breast cancer that's in remission or with localized disease that's been cured? What's the best strategy for them to not get metastatic breast cancer?
It's a fantastic question. So the question really is how to delay or prevent the appearance of metastatic disease. So first, it is to complete the treatment, right? So I would say that for those who have hormonally sensitive disease at diagnosis, to make sure that there's been a good, long, well thought out plan to treat for many years with hormonal drugs in what we call adjuvant setting. For those who had HER2 positive disease, it's to have completed also the specific targeted therapy for HER2. And for those with triple negative disease, usually the treatment is a little shorter because we don't have these long targeted adjuvant therapies. And once you're there, then I think it's a matter of trying to stay healthy. So here are some of the things that we know that can help keep people healthy. We know exercise and vigorous exercise is emerging as being, very, very, very good. It can help reduce relapse. It can help reduce other problems like heart disease and so on. So I think vigorous exercise is one. Getting enough sleep, I think, is important. There are fewer studies on sleep, but we are beginning to acknowledge how important that is. A good diet, and I don't have any specific advice about what diet, but I would say a good, cardiovascular diet, plant-based diet is important. Alcohol in moderation. There is some debate, and you'll see in the guidelines, even from the National Consortium of Cancer Network, the NCCN guidelines, that they really recommend very little to no alcohol. But, we don't know how to customize that recommendation, but we do know from epidemiologic studies that high consumption of alcohol can increase the risk of recurrence. So I would say, take it down. I wouldn't say that we need to eliminate it completely, but to limit the intake. So, you can't change your family history. You can't change what you inherited. You can't change what happened, but you can try to do things to stay healthy, mind, body, spirit. So sleep well, eat well, exercise a lot, do preventive care. And then, I don't have any specific advice. There have been no particular supplements or one particular diet that has stood out or really been tested scientifically and shown to reduce the risk. I wish there were, but at the moment, I think we don't have one particular type.
Great, thank you. I appreciate pointing out the modifiable and unmodifiable things in your life and focusing on the modifiable one. Another question is about clinical trials. What do you recommend in terms of resources patients can turn to find out about clinical trials? And then how should one approach their doctors or care team about them?
That's a brilliant question, one I've come across very often. So clinicaltrials.gov gives you the trials, and there actually are quite a few websites, and I don't know them offhand, but I'm sure I can find them. There are actually groups that help people find trials. So there are places you can go to and turn, and you can just sort of put in the kind of disease you're looking for, and out pop the trial. So finding somebody who can help a person do that is really important. And then at least you see where the science is happening, what sites are open. A clinical trial may be hosted by one institution, but may be open in another 10 or 12. And then you want to sort of see if there's a trial near you, for instance, that you qualify for. So that's what you can do on your own or with a friend or with a coach who can do that for you. And then the other part of the question is really, I think, key as well. And that is, really discussing with your clinician that you're interested in participating in a clinical trial and establishing that connection so that you ask them to help you find a clinical trial that you're eligible for. And over the years, I've been asked this question so many times by friends who have a family member or relative that's diagnosed and they don't sort of know how to open the conversation with their physician. I think you just have to do that and say, I'm interested in finding out what research options are available for somebody like me. Can you or somebody on your team help me find that? And can you keep that in mind when we are at a point where we have to change treatment? For those of us who are working in research-based institutions, every time there is a change of treatment is a point where we sit down and think, is there a trial for this individual at this point? So I think those are the natural points where you want to think about it. And I think that there's no easy way but just to ask the clinician for help and for partnership. I can't hear you, Carly. I'm so sorry. I think you're still muted.
Apologies. I'm sorry. I was muting the background. I thank you. Thanks for that answer. I was just saying at Bay Area Cancer Connections, myself and my colleague Erica in our cancer education and information department have helped people research trials and explore some of the sources you mentioned. So thank you. end with the last question. What would you say, Dr. Schapira, as a physician, to someone who is diagnosed with metastatic breast cancer today in terms of the treatment outlook and sort of the future? This is sort of a broad, more philosophical or spiritual question about the future of their disease and treatment course in the coming years.
Yeah, so it when you ask me that question, I immediately go back to a moment a few years ago when a dear friend of mine was diagnosed with metastatic breast cancer, de novo metastatic breast cancer. So that means that she was one of those, unlucky people who are in that 5% whose first diagnosis is when the disease is metastatic. And I really felt with her and I wanted to help her. And so the first thing I said is, we're going to do this. So to think about creating the team, creating the support, choosing her clinical team very wisely, and being able and making sure that she would, I'm not going to use the word love, but at least appreciate her clinical team and feel comfortable and feel known and feel they had her back. So what I said to her is, let's build your pillars of support. Let's make sure that you decide on how much information you want to convey to those in your family or at work, and who needs to know what, and that you direct that. How to protect the life in your family that you so much value, how to keep things as normal as possible. How to define your goals, like what are you looking for in a team, what are your objectives? And of course it was to live well and to live long. And then she chose in her particular case to actually start with clinical trials and became a staunch advocate for that. And I think it helped her in some ways, and that may not be for everybody, but I think for anybody diagnosed with metastatic breast cancer, to have sources of support such as the Bay Area Cancer Community, there are national organizations living with metastatic breast cancer, living with breast cancer, that are for this population. So connecting with others, hearing from others, trusting the team, feeling informed, and asking for help if things are not going well, knowing also when to ask for help, and not forgetting that all of these supportive therapies add a lot. Having perhaps somebody who can assist with physical therapy if there's a particular part of the body that's not working well, or mental health if that's the case. I think that's the best advice I would give anybody, and to take it one day at a time, and celebrate and be joyful about what we've got.
Yeah. Thank you. That's excellent advice. Well, thank you again, Dr. Schapira, for this talk. I'm encouraging everyone on here we have a few minutes until our next session at 2:45. So encourage everyone to check out our resource fair, take a bit of a break. And again, thank you, Dr. Schapira, for joining.
Thank you very much for the opportunity. Take care.